Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly above the chat pod. It is now my pleasure to turn the conference over to today's first presenter, Mr. Chris Hund. Sir, please begin.
Thanks, Chelsea. Hi, everybody. Good morning, good afternoon, good evening if you're somewhere else in the world. Thanks for joining us today for the AHA Team Training Monthly Webinar here for October 2019. My name is Chris Hund, and I'm a director here at the AHA Center for Health Innovation, as well as the director of AHA's Team Training Program. Today we have Making the Case, how team-based approaches improve value. And so excited about this today. We often have a lot of people ask us, to help them with those cases, to help them understand how they could talk to others about why team-based care is important. And so this is going to go a long way, I think, in helping that. Just some rules of engagement today. You can listen to the audio in two different ways. You can listen to the audio through your phone, and if you do that, please mute your computer speakers, because otherwise you'll get a very strange feedback sound. Or you could listen directly through your computer. That's a fine thing to do too. We just have the phone option in case you have a bad internet connection. There will be a Q&A session at the end of the presentation. The reason we do this is we encourage people to submit written questions throughout the presentation, and then I'll gather all those written questions up and do a Q&A at the end and try to do it in a logical, ordered sense. So as you think of questions as we go, feel free to chat them in to the box that says chat on your screen as we go, and we'll collect those and do a Q&A at the end. A couple other announcements about AHA Team Training events coming up. In a few weeks, we have a brand new course we're offering at Duke University in Durham, North Carolina. It's Team Steps Master Training course for outpatient care. And so this specifically focuses the Team Steps examples and materials and videos on the outpatient world. So primary care, medical offices, ambulatory, really anything that's non-hospital based, that's what this is for. We also have registration open for our 2020 courses. Hard to believe it's 2020 in a couple months. So those are master training courses, Team Steps fundamentals courses, which are courses that are focused specifically on the tools. So they're great for people who want a refresher or for people who are not interested in becoming master trainers and just want to learn about the tools. And then also other specialty courses that are available. So make sure to click on over and learn more and register. Next month's webinar is Strategies for Staff Engagement, Leading the Low Performer, and that's on November 19th at 12 Eastern, 11 Central. So we look forward to having you on that. Please register as you see fit. Our big announcement goes around the 2020 AHA Team Training National Conference in beautiful New Orleans in the French Quarter. It's going to be a wonderful conference. It always is, I feel, June 3rd through 5th. And this conference is really built by the attendees. It's very DIY. It's very much based on what you want to learn about. That's what's going to be at the conference. So head on over if you want to present to the call for proposals. You'll see the link there. The call for proposals is open for a bit more, and we really encourage people to put something in. We're trying to bring as much information around how teams positively affect the healthcare experience. So it doesn't have to be about team steps. It can be, but it doesn't have to be. We're really looking for how the entire team, the world of teamwork helps improve patient experience, the experience of the healthcare worker, be it providers, nurses, staff members, really anybody. So that's what we're looking for. It should be a lot of fun. We're looking forward to being in New Orleans, in a very historic part of the city. So I think it has a lot to offer. Looking forward to seeing you there. As always, give us a call if you need us or shoot us a message. We'll get back to you, answer any questions you have, both content-wise about what AHA team training does and if there's any sort of logistical, operational type questions you might have too. Okay, without further ado, I'd like to introduce Priya Bathija. She is the VP for the Value Initiative here at the American Hospital Association, and she's going to be our presenter today for making the case how team-based approaches improve value. So, Priya?
Great, thanks Chris, and good afternoon everyone. Today we're going to discuss the importance of using team-based approaches to improve value for patients and communities. I'm going to start by providing an overview of the national context and the call for greater healthcare affordability and value. And then I'll share how teams can advance value, including real-life examples of how hospitals and health systems have engaged teams to lower costs, improve outcomes, and enhance the patient experience. And then I'll end by sharing sort of a rough framework that you can use to begin measuring and examining the value of team-based care, and really get you thinking about the best way for you to share your story for how your team-based approaches are working to improve how care is delivered to your patients and communities. So let's get started. When we look at healthcare today, there are a lot of financial pressures, and affordability is a huge issue. Through the field, we've done a lot to address coverage, but it's still not really leading to access to healthcare in a lot of cases, and that's largely just because healthcare has become so unaffordable. On this slide, you can see how healthcare has become unaffordable for employers. Their healthcare costs continue to rise, and they are spending more and more on healthcare each year. And looking to the next slide, we see that more and more employers describe their company healthcare costs as out of control each year. Employer-sponsored health insurance is expected to grow to be about $9.3 thousand per person by 2027, and that is double what it is right now. And so with consumer out-of-pocket costs also rising, employers are having a really hard time passing along costs because their workers really don't have any more to give. If we look at affordability from a government perspective, federal and state governments are also feeling these financial pressures, and they're forced to make the choice of whether they want to spend on healthcare or other needed services like schools and roads. So here you see that per capita spending continues to rise for federal-sponsored health plans, and that's largely due to program and coverage expansions that we've seen over the course of the last decade. In 2016, our country as a whole, and you may know this already, has spent over $3.3 trillion on healthcare, and that number is expected to rise to $5.6 trillion by 2025. So that's 1/5 of America's economy. So how we spend those dollars is continually a subject of conversation, not only in Washington, D.C., but in your state governments as well. And now if we look at individuals, they are feeling the brunt of all of this too. We know today that 9 out of 10 Americans have health insurance, but as I mentioned before, and as we see day to day, coverage does not necessarily equal access to health care. And individuals are being put on the hook for more and more of their health care costs. So right now, a typical family of 4 with large employer health coverage spent $7,726 on premiums and cost sharing in 2018 alone. And that's 18% more than it was just 5 years ago in 2013. And that growth far outpaces the growth that we've seen in inflation and wages in that same time period. So as a result, and another point is that 1/3 or more of Americans do not have enough savings to actually cover their deductibles right now, because the average deductible for employer-sponsored plans tripled between 2008 and 2018. So we're seeing a huge increase in the amount that consumers are required to pay up front for insurance coverage, and that is then exacerbated by the amount that individuals are required to pay for deductibles as well. If we look at this another way, we see across the country that families are spending more on health care than they have ever in the past. Since 2007, middle-class family spending on health care has increased by 25%. And so the natural consequence of this is that they have less money available to pay for other basic needs like food and clothing. And the result of all of this for consumers is that Americans are putting off needed care because of cost. Nationwide, we see that 1 in 3 Americans put off needed care because it costs too much. And 1 in 4 have said that the cost of health care is the most important concern facing their family. So it's no longer whether they can afford to send their kids to college, it's whether they can afford to take them to the doctor and to get prescriptions filled. And hospitals are also feeling this pressure. For example, the cost of caring for patients continues to rise. One example are skyrocketing drug prices. Total annual spending on prescription drugs has reached $309 billion, and that makes it the fastest growing segment of the U.S. healthcare economy. And as a result of this growth of drug prices, inpatient drug spending per admission has increased substantially since 2013. In addition to those rising sort of input costs, hospitals are also feeling the burden because they are treating individuals who have more challenging conditions. So healthcare really is expensive because Americans are sick. As you see here, the number of Americans with chronic conditions is rapidly rising, and more than 100 million adults now, which is almost half of our entire adult population, have prediabetes or diabetes. Cardiovascular disease afflicts about 122 million people in America, and 3 in 4 adults are overweight or obese. So more than half our population is sick, and with aging baby boomers, that isn't going to change. And of course, right now we are spending 86% of all the money we spend on health care is on patients with 1 or more chronic conditions. And as we move into the future, that is expected to increase, which means that people will be using more healthcare services, which cost more, and we are going to be paying a lot more for healthcare. So in looking at all the data, the obvious question is, what do we do to address this affordability crisis? And in 2017, AHA had a dialogue with over 700 hospital leaders, and they shared that value could be a path forward to better healthcare affordability. And of course, value is different for each of us. For some of us, value is purely cost. So valuable care is affordable. Others see value in having the newest and best medical treatments and technologies, regardless of cost. And then to some, value is tied to easy access. So healthcare services that are on demand and easy to schedule with no wait times. So as a result of everyone having different opinions on what value is, there really is no standard definition of value across individuals and definitely across the healthcare field. So based on the member feedback that we got from those over 700 hospital leaders, the AHA decided to take a broad approach. And our goal is to capture what individuals are actually getting for each dollar that they spend on healthcare. And so when we look at value, we're looking at cost, outcomes, and the patient experience. And we know that a lot of hospitals and health systems are implementing a variety of value-based strategies to improve each area of that value equation. And we've lumped the work that we're seeing across the country related to value into 4 categories, which are on this slide. Redesigning the delivery system, improving quality and outcomes, managing risk and offering new payment models, and then implementing operational solutions. We know that the models that are listed here aren't a full, complete list of all the models that are happening, but these were some that sort of were more common and made it to the list. And as you can see, these models aren't limited to payment-driven models like ACOs, bundle payments, or medical homes. We really are looking at this issue of value broadly, and we're looking at how hospitals are coordinating care, addressing the social determinants, and implementing high-cost approaches, among other things. So very broad view. And while there is a lot of discussion in the field today around technology, as we look at these value-based approaches, we're also looking at a mix of approaches that are high-tech and low-tech, because we know that all hospitals around the country aren't going to be able to implement artificial intelligence or precision medicine right away, or maybe not even ever. And so we really are focused on how can we also look at low-tech strategies that hospitals can implement to advance value, or low-tech strategies that can be used to support and promote high-tech solutions that have also been implemented. So just so we're on the same page, when we talk about low-tech solutions, and what we're looking for are those solutions that are tech-light, so they're only tangentially reliant on technology, and when they are, they're technologies that are already in place, so no new or costly equipment. They're simple, basic, and uncomplicated in form or design. They're human. They rely upon a human connection and interaction that can be used to improve care coordination and integration. And then lastly, they're scalable, solutions that could be implemented by every hospital across the country so that we could see broad implementation. So one of those low-tech, value-based strategies that we have been looking at is team-based care, because we believe team-based care has tremendous potential to improve value. We know that healthcare teams come in all different shapes and sizes, and that each is unique. It has its own purpose, its own size, setting, number of core members, and methods of communication. So some examples, there are disaster response teams, there's teams that perform emergency operations, teams that are caring for acutely ill patients, teams that are going into homes to care for individuals, teams that include patients and loved ones and a number of supporting health professionals, and teams that include players from outside the hospital, so other community-based organizations. We know there are a lot of different approaches that can be taken here, but we want to try to encompass as many of these as possible. And I really love the quote on this slide about the power of working as a team. Each team member really does have something unique and crucial to contribute, and brings a different piece to the table. So next, I have a poll question for you, which is, do you work on an interdisciplinary team? So if you could respond to the poll, we'll take a look at how many of you are actually part of one of these teams. Okay, great. It looks like most of you are either working on teams at a frequency of often or always, which is great to see and hear. And we have one more poll question. Let's see if it goes. And that is, how common are interdisciplinary care teams used at your organization? Okay, it's great to see that they are being used on a very common basis at your hospitals. And we'll spend some time now, and I'll go through this briefly because I know you're on a team training webinar and a lot of you are working in these teams, but just let's talk briefly about what is team-based care. And this slide shares the National Academy of Medicine definition for team-based care. But generally speaking, team-based care includes a group of individuals who coordinate their actions for a common purpose. And in healthcare, that can be the prevention or treatment of a disease or the promotion of health. Teams can include clinical and non-clinical professionals, and each individual that participates in a team is encouraged to function to the fullest extent of their education, certification, and experience. In addition to this definition, the National Academy of Medicine has set forth principles for high-performing teams that need to be present in order to enable success. And as you know, implementing team-based care really requires a culture change in how care is organized, how professionals interact with each other and with patients, and how healthcare providers are educated and trained so that they can be prepared to participate in team-based care. So it really takes work to make team-based care work, and these principles are a good framework for what you're trying to achieve in terms of teamwork, but really need to be implemented intentionally and worked on and refined over time. And then if we want to look at who should be on the team, as I mentioned earlier, teams come in all different shapes and sizes. But in healthcare, we see a lot of interdisciplinary teams of professionals from different professional disciplines who come together and work together to manage the physical, psychological, and spiritual needs of a patient. They're not solely clinicians involved with providing medical care to patients. This slide shows an example from Hospice of Northeastern Illinois. Their interdisciplinary team includes volunteers, chaplains, social workers, and others, each of whom has a key function in delivering patient-centered care. You'll also see from this diagram that each member of their team has their role to play to support the patient and their family. The patient really is the center and should be an active participant in any healthcare team. So how many of you are actively engaging patients and families as part of the interdisciplinary teams that you're participating in? Okay, so many of you are, but this does look like an area where we could do some more work around because many of you are responding with sometimes, rarely, or never. So in addition to including families and patients as part of the team, teams aren't necessarily limited to the four walls of our hospitals. And based on a patient's needs, care teams can include providers that are outside of the hospital. They can also extend further into the community. As you look, for example, to address patient social needs or the broader social determinants of health in your communities, thinking expansively about who should be on that team will be an important step. And I'll give you some real-life examples in a little bit that show how broadly you could be thinking about who is on that team. But from this slide, you can see that potential community team members could come from community-based organizations, schools, social service organizations, or faith-based organizations. So another polling question, how many of you are engaging those that are outside of your organization as part of your care teams? Okay. This is great. A lot of you are working with these types of organizations, and I think that this is an area where we're seeing a lot more movement across the field where hospitals are beginning to incorporate individuals from other organizations, particularly while they're addressing the social needs and social determinants. So it does seem like all of you are on track with that work as well. So given that teamwork takes so much work and could require a significant culture change, the question becomes why do it? Why put it to work? Why implement team-based care? And I know, again, you're on a team training webinar, so you're familiar with many benefits of teams, but team-based care really has the potential to improve the value of healthcare. As you can see here, this data from the American College of Cardiology shows how it can improve each component of the value equation. For example, if you're looking at cost, teams can lead to more efficient care and improved financial outcomes. Effective team-based approaches also lead to improved quality outcomes. And of course, team-based care can include benefits such as patient and employee satisfaction. And we'll talk about this in the upcoming slides. And now for the final polling question, does your hospital measure the impact of team-based care on value? Okay, so seeing that a lot are not doing this at this point, so it's great that you're on this webinar, and hopefully some of the examples that I start sharing now will help you think about how you can be moving towards that as you continue your work, your team-based approaches. So now we'll walk through some examples of how hospitals are implementing team-based care and how those efforts are improving value. So let's start with Intermountain, moving that slide. Intermountain Healthcare. They have a mental health integration model, and through that model they are integrating behavioral health into every patient visit. During primary care visits, patients' behavioral health needs are assessed and stratified by complexity. Then a team develops an individualized care plan that supports recovery for both the patient and their family. So in addition to primary care clinicians, the customized care team could include social workers, therapists, psychiatrists, care guides, care advocates, care managers, physical therapists, nutritionists, pharmacists, and peer mentors. Intermountain, because there are so many different players on these teams, has also developed a playbook that outlines the roles for each of these team members, and they continually link the work that the team is doing back to the primary care provider. Their outcomes from this work have been quite impressive. Through implementing this team-based approach, Intermountain has saved about $13 million per year. And the strategy continues to expand throughout the health system and soon will be used in over 90 clinics within Intermountain. Intermountain has been studying the impact of this program and the impact specifically that it has had on value. And they recently published those results in JAMA. And that cost savings I mentioned of $13 million comes primarily from reduced utilization. The program significantly reduces utilization of the emergency department, the need for hospital stays, and the number of primary care encounters. In addition to cost savings, Intermountain program has improved outcomes. You can see that more patients are being screened for depression now than they were in the past. And more patients are adhering to diabetes protocol. So it really is that integration of mental health and clinical care together, leading to these positive results. The next example I have is related to an integrated primary care and behavioral health model as well. It also addresses one of the questions we received from all of you before this webinar started, which is how can care teams be utilized to improve care for vulnerable populations? This is an example from Montefiore Health System in New York, and they are utilizing an integrated team of primary care providers and behavioral health specialists to better serve its large population of low-income and minority patients that have significant medical and mental health, comorbidity, and socioeconomic challenges. And their goal was to improve patient outcomes and facilitate faster recovery with having better communication with providers. So in addition to just having an integrated care team, they've also used technology to supplement the care team's work. They have an app that allows a case manager to keep in touch with patients when they're out of the hospital and check in on their health. And the case manager connects back to the care team to ensure that the patient situation is evolving. Patients have expressed that they really like being more connected to their care team and having a care team. They felt that it helped them meet their better meet their health goals. So as you recall, enhancing the patient experience is one part of the value equation, and Montefiore has really seen success in this program in terms of how they are engaging with patients and how patients are engaging with their care teams. The next example is from Sharp Healthcare in San Diego. They have a multidisciplinary palliative care team that provides in-home care 24/7 to patients with advanced chronic illness. The team provides in-home consultations with a focus on pain and symptoms, education, and spiritual support for the patients, caregivers, and assistance with treatment choices and advanced care planning. The team essentially addresses a mix of medical and social needs. Unlike just hospice alone, this transitions program is delivered concurrently with ongoing treatment. So patients continue to see their primary care physicians and specialists. And this is really an added layer of support with 24/7 telephone access to transition nurses that can respond to crises when they happen. As a result of this program, Sharp has cut hospital admission in half for these patients, and for those that need to be admitted, the length of stay for those admissions has been decreased by 50% or more depending on the medical condition. They've also seen significant savings per month per participant, and those range from $2,600 to $4,200 depending on the condition in which they are treating. So on the slide you can see the $2,600 savings from dementia and spanning up to $4,200 approximately for cancer patients. In addition, in the questions that we received prior to the webinar, a couple of you asked how teams can promote value in rural settings. So this example is a great example, example of how a rural hospital has implemented interdisciplinary care teams to do just that. So this example is from Columbus Community Hospital in rural Nebraska. Their interdisciplinary care teams huddle twice per day to discuss the needs and progress of each patient, essentially planning the care for patients that after discharge while patients are still at the hospitals. Their teams include 3 registered nurse case managers, hospitalists, social workers, pharmacists, nurses, and a clinical therapist. The teams conduct risk assessments to identify patients that are most likely to be readmitted, such as those with a history of frequent emergency department visits or comorbidities. They also spend a lot of time examining social determinants of health and matching patients with those resources within the community if they are needed to help promote their health and wellness. So this is an example of how teams can work outside the hospital as well, because Columbus Community Hospital really focused on strengthening its communication and care plans with providers that were outside of the hospital, including staff at skilled nursing facilities, with home health agencies, assisted living facilities, and then retail pharmacies and medical groups. So really showing how teams can work across really the whole healthcare field and not just within the four walls of a hospital. The results of their work has been really positive. They have been able to reduce readmissions by 42% and save upwards of $819,000, almost close to $820,000 in just 18 months. This resulted also in, so you see the savings, but this has led to, and when we talked with Columbus Community Hospital, has really led to increased patient satisfaction from their patients, because less time spent in the hospital and more attention to the actual services that are needed to improve health makes patients happier. It makes lives easier for families. It makes it easier for patients to participate in their care plans. So they are seeing a lot of great results in that rural community. Next, I have another example from Sharp Healthcare in San Diego. This is Sharp's Grossmont Hospital, and it's another example of how they're utilizing community-based organizations as part of the team. Their care transitions interventions program involves a multidisciplinary team of health professionals that includes registered nurses, medical social workers, and financial service advisors that provide care transition coaching for vulnerable patients. Patients are identified as high risk through a comprehensive risk assessment tool that Sharp has developed that assesses patients for both clinical and social risks. In this program, they collaborate with community organizations to connect patients to critical services such as fresh food, transportation, and social support. Sharp has extended this team to include those outside the hospital, and one example is their partnership with 211 San Diego. This partnership allows 211's health navigators to be part of the team and to connect the patients that are participating in this care transition program with the resources that address both short and long-term care needs and the social determinants of health. So again, their team extends outside of the hospital, and they also are seeing some really great results. They've reduced readmissions in this population to under 10%. They've reduced healthcare costs by nearly a third and have seen reductions in the length of stay. We have a couple more examples. The next one is from Clinch Valley Medical Center in Virginia. They partner with the Appalachia Agency for Senior Citizens to avoid readmission and emergency department visits. There they have a core team that is made up of staff from both the hospital as well as this Agency for Senior Citizens, and it has caseworkers, pharmacists, respiratory therapists, and representatives from the primary care clinic. And they actually make home visits to patients who have been recently discharged to, again, address upstream health issues and the social determinants of health that may hinder patients' recovery and well-being. At any time, this team is tracking between 15 and 22 patients that have complex health issues. They use technology, and it's low-tech because they're using texting to really keep the care team up to date and alerting them when concerns arise. The team has been able to reduce avoidable readmissions from 11.8% to 7.8% since being in effect. And this example has had a real impact on consumer costs for healthcare. If you've noticed, most of the examples I've shared have lowered costs, but those are costs that stay within the healthcare system and don't necessarily make it to a patient's bill or a patient's out-of-pocket costs. But this example has had a real direct impact on consumer costs. So they have identified one patient who had their monthly cost of prescription drugs decrease from $1,700 a month to $200 a month. So really seeing some real results for patients as well as the hospital through this team-based approach at Clinch Valley. Another one is Sinai Health System in Chicago, and this one is unique because they actually include community health workers and patients as part of the care team. So they use community health workers to reach outside of the walls of the hospital to support asthma patients in their homes. So patients and families actively work with the community health worker, and then the community health worker has a loop-back mechanism to the care team. So everyone is coordinating the care that individuals with asthma have both at home. And as a result of this program, patients that are enrolled miss fewer days of school, they're more physically active, and they lose less time from work. They've also seen a 60% reduction in asthma symptoms and the use of inhalers. And as a result of the program, patients spend 80% fewer days in the hospital, and they are 75% less likely to visit the emergency room. This program has been around for about 8 years now, so they've really been able to track the results that they're seeing by engaging patients and families and community health workers as part of the team. And they estimate that they avert between $3 and $8 in healthcare costs for every dollar that they spend on the program. And then, since this is Team Steps, I wanted to include one example here from Metro Health in Cleveland, and many of you may be familiar with the work that Metro Health is doing around Team Steps, but they have trained all of their staff, both clinical and non-clinical, in Team Steps. They've identified champions. They've established 15 action councils that develop and evaluate quality improvement projects. And the impact of all of this is that they have significantly improved their ARC patient safety scores and increased safety event reports, which are all great metrics towards tracking the improvement in value. And so with all of those case examples, I want to distill it a little bit down into how you can be looking at a framework to think about metrics that tie your team-based approaches to value. So here, of course, we have the 3 parts of the value equation, and we'll go through each of those. But before I do that, I do want to mention, we know that there are a lot of different things that you could be measuring in response to team-based care. So you could be measuring sort of the internal improvements. So those are the internal benefits of having teams, such as decreased burnout or improved job satisfaction. But there's also this piece that we'll talk about now, which is how team-based approaches can benefit this value equation and benefit patients, families, and communities. So that's really where we're focused on. We know that there are a lot of other benefits outside of this framework, but we want to sort of bring it to this value equation for consumers and patients. So, you can start by looking at quality outcomes that can be used to improve value. So here you want to measure both improved processes as well as improved outcomes. And I've included some examples here. So in terms of measuring improved processes, you could look at the amount of time it takes for a patient to receive a service, or the percent adherence to an evidence-based guideline as a result of your team-based approach. And if you're looking at outcomes, you could look at, as many of the examples I shared, they looked at readmission rates, and they looked at ED admission rates. You could also look at complication rates related to a particular condition as well. And then moving to the next area of the value equation. Sorry, I jumped too ahead, but I'll leave the slide right here. Looking at patient experience. So here's where you want to measure experiences and what really matters most to patients. So you can look at patient satisfaction through the HCAHPS scores, but you also want to try to really get to how patients are actually engaging in the experience, and so that can be done through department or unit level surveys, interviews, or focus groups. And just want to stress that as I go through some of these examples, you'll see that you'll want to use a mix of qualitative and quantitative research and data to really come up with that full approach of how you want to tell the story of what your team is doing. And this patient experience area is a really great area to use sort of the anecdotal experiences that your patients are having as they're engaging with teams. And then the last part of the value equation is, cost. So measuring cost savings, and we know this one is hard to do, but if you can estimate sort of the savings you have from avoidable readmissions or decreased utilization of ED or urgent care services, you'll kind of get to a number of what you're saving. And that's really important, and I think it's an area that we often as hospitals don't sort of pay attention to, because we are really focused on improving quality outcomes and making sure our patients have the greatest experience. But as we continue to sort of move forward in these conversations around value and moving from fee-for-service payments to payments that actually incentivize keeping patients well and focused on health, these numbers around what these approaches are able to save in terms of cost will be really important in sort of moving the needle in that dialogue. So I will stop there for the most part so that we can take some questions, but I do want to highlight through the Value Initiative, we've come up with a lot of tools and resources and best case practices related to value, and I urge you to check out some of those activities or our in-person live education events, and all of those materials are available at this website. And my personal email is my work email is on this slide. So please feel free to reach out to me or reach out to the team training team, and they will get in touch with me about any questions you may have about what I presented today or the work that we're trying to do through the Value Initiative at the AHA. And with that, Chris, I'll turn it back over to you to see if we have any questions.
Priya, thank you so much. I really appreciated that. That was a great presentation. So thank you very much. A couple of questions. I think there's been a couple that are very specific to certain things, and then one that is a little bit overarching. So I'm going to go to the overarching one first. And you spoke to it a little bit on your last slide with content when you were talking about cost and patient experience and quality. So how would you make the case for having those cost conversations with frontline staff? I think that quality of care obviously speaks to people who are working, on the front lines. Patient experience does, because exactly what you were just saying at the end there. Like, we're used to talking about that. We want our patients to have the best experience. We want to have quality care and safe care. Where can we make those connections, though, along the lines of costs? Not just savings for the hospital, but savings for the people using the services, the patients and the families.
Right. No, I think that's a really great question, and it's an area that I haven't 100% figured out an answer to, but we're trying to get there through the Value Initiative. And I think when you're looking at cost savings to patients, I think where the conversation is with frontline staff is getting them, perhaps in some situations, comfortable with talking through treatment options and what may be cost-effective or not cost-effective for an individual. And again, that goes back to that conversation of figuring out how do we truly have those dialogues with our patients about what matters to them, and then what's the best treatment to get them there. And we have sort of a lot of work to do there in the hospital field, because a lot of those conversations are not happening, and so they're not driving us to a more global conversation about costs. And there's a lot of factors for that. I mean, I think frontline staff are a little bit uncomfortable having those conversations, and naturally so. I would be uncomfortable in having those conversations. But I also think it's a data issue too. It's hard to get real-time costs to the care team. It's hard for patients to find out their real-time costs. So there are a lot of obstacles that we sort of as a healthcare field need to tackle together to get to the point where those frontline employees, whether they're clinicians or non-clinicians, may feel more comfortable or may have the information that they need to actually have those conversations. And I think when you look at cost in terms of how it's impacting the hospital and the system, having those conversations with the people actually delivering costs, I think, comes about a lot in terms of like budget discussions and how can we sort of save money so that we have it to use for other things. And it's just another area where we need to do a lot more work on. So I apologize for not having a more specific step-by-step answer there. I think it's an area where we all need to sort of focus on to improve.
No, that was, thank you very much. Another question that just came in, is talking about how applicable team-based care is to, and what are some of the essential factors for outpatient, primary, and specialty care. And from my perspective on this, there are a lot of elements of team training that goes into helping in any of those outpatient settings. We're maybe not looking specifically at the same quality metrics, the same safety metrics where we're looking at infection prevention or readmissions or things like that. But there are a lot of other things that one looks at in those environments. So, specifically things like wait times, and wait times have a lot to do with patient satisfaction. They have a lot to do with staff satisfaction. If I'm a nurse and I'm missing the soccer game for my son because everybody's behind again and I can't pick him up and take him to his game, that really impacts my staff satisfaction too. So I think that's one area. I have a couple other areas. Do you have anything, Priya?
No, I think those are all great, and I think that the sky is sort of the limit, and each hospital really needs to sort of come up with a framework that makes sense in terms of what their teams are doing and what their patients and employees are sort of facing. And I think that point you make about looking at employee satisfaction is so important, and I didn't incorporate it here, but I think in real time, in real life, in hospitals, that should be incorporated as well, because if your employees are burnt out and they're not able to do things, or if your employees are annoyed or it's a nuisance to have them do things in a certain way, those are areas that are ripe for process improvement, performance improvement, as well as sort of just value improvement.
Sure. There's a lot in team-based care around, closing the loop in communication and communicating in a standardized way. And a lot of times people think of that maybe just in emergent situations, acute situations, during surgery, but there are a variety of case studies out there about, information not being properly conveyed or the loop not being closed in simple things around medications or about next steps for a patient that have led to catastrophic disasters. So, it's definitely all very ripe there. Like you said, the sky's the limit. So a lot to be done there. And a nice plug for our Team Steps for Outpatient Care course happening in 2 weeks at Duke. So that was a good question. We have another one here. Priya, if you look over in the presenter chat box, which Abby sent into us, the one about, the question is, the crushing cost and inflation of healthcare seems to be the overriding issue facing us all. So doesn't moving towards value create an unproductive deflection? Why not focus on costs without deflection? To me, that would move us more quickly towards organizational sustainability and addressing the incentives that run counter to cost control.
So that's a really good question. And when we started the Value Initiative, and honestly, even going back before the Value Initiative, when we were having those conversations in 2017 with our larger membership, that came up a lot. And it was, how can we really move the needle on affordability if we're looking at other things? But we had to keep a lot in mind when we came up with that value equation and this approach to affordability. And the biggest part was that we wanted hospital leaders to engage in this conversation and dialogue and to really understand what was happening in the field and the challenges that were coming at us. And to do that, we needed to do it in a way that all leaders could engage with us. And that really is looking at cost, outcomes, and patient experience. And I will say that, a lot of people think that we're deflecting, but I would argue that we're not. And the reason for that is, and it came across in one of the events that we had for the Value Initiative, we had a guest speaker, Elliot Cohen, who is the founder of PillPack. And I'm not sure if everyone's familiar with PillPack, but they are a pharmacy service that was recently acquired by Amazon. And as he was talking, he said, in our industry, in the healthcare industry across the field, there is so much focus and attention put on incentives and payments and cost. And if we were really to take a step back and just focus on the consumer experience, and we were to really focus on the quality of services we were offering and the experience that our consumers were having when they were receiving those services, we would naturally get to a point where we have lower costs. And that would be because we are actually talking to our consumers and we are asking them what matters. We are aligning care with what matters. And as a result of that, those patients are engaging in their care in a different way than they have in the past. And all of those steps ultimately and naturally will lead to lower costs over time. So in hearing conversations like that from industry leaders that aren't necessarily within our hospital community but are in healthcare, they're touching healthcare, they're impacting how healthcare is moving forward in the future, they're really looking at that consumer experience and going backwards. And I think as we hear those experiences and we translate them to healthcare, I think our members, when they came back and said we should focus on value and not just cost, I think they had it right. And I think we need to look at all of these things together. And so I don't believe it's a deflection. I think it's just a path forward.
Thanks, Priya.
Yeah.
All right, let's see. We don't have much. We have 2 or 3 minutes left. I think one question, and I might know the answer to this, but I'm going to ask you first, is one that's been sitting here for a bit, is how are we surveying patients regarding patient experience? If every patient isn't provided the opportunity to provide feedback, the data will be skewed. From my mind, that's looking at, surveys like, CAP surveys that come out that I get in the mail when I go see the doctor. Is that where you're going at with this too?
Yeah, I mean, I think that's part of it, right? And I think, again, and, each program or each hospital will develop the right sort of metrics to get that or the right sort of mechanisms to get that information. But I think you can definitely look at patient satisfaction surveys. We've seen a lot of hospitals actually create special surveys for the patients that are receiving the team-based approach care. We've also just seen anecdotal stories, and that's where I'll go back to. Like, I think when you're looking at patient experience, that's a great place to use a mix of the quantitative and qualitative data to really tell a story of the impact this is having. And it can be down to one patient, to say that one patient did this, and then that's going to grow. As the program continues, you're going to get more and more of those anecdotal stories. And so it may not be perfect from a data setting, but when you're telling the story of how team-based approaches are improving value, really just, we can't let the perfect be the enemy of the good. And so it may not be 100% statistically significant and accurate, but as you're telling your story to your hospital leaders and your boards, those are the types of things that you can rely on to show that this is working, this is the right direction, we need to keep moving so that we can get more data.
Oh, that's a great way to close. I have a friend who often says, they never did any randomized studies or tests of whether or not the parachute worked. No one jumped out of the plane without a parachute. So it's what works, what you kind of have that feeling that does sometimes because of those anecdotal stories.
Right.
All right. So if anybody has any other questions, Priya's email address is here on the slide. She said she'd be happy to answer any other questions that you have if you want to get to her directly. I'm sorry I didn't get to all the questions, but we are at the end of the hour. I'd like to thank you all for coming. There will be a link coming your way to do a evaluation of the webinar. We really appreciate if you do that. It helps us kind of improve these and know where to go and know what topics to focus on. And I'd like to also thank Priya very much for joining us today. I really appreciate it.
Yep, happy to be here. Please let me know if you have any questions.
Thank you, ladies and gentlemen. This concludes today's teleconference and webinar. You may hang up your phone and disconnect. Please enjoy the rest of your afternoon.